I'm Claire Mulhern. I'm the Chief Public Affairs Officer for Agilon Health. We are incredibly proud to be a founding member of the Primary Care for America Collaborative. Agilon Health was founded in 2016, really to focus on transforming primary care in this country. We develop long-term partnerships with independent primary care practices across the nation to really focus on delivering full capitated value-based care. Today we operate in 12 states across 25 communities, and next year we'll have close to 500,000 senior lives under fully capitated risk, which is an incredible journey over a very short period of time. What I do want to do, I hope we do have her up on the screen so I don't have to stall too much longer. So with that, I'm going to turn it over to Stephanie Quinn, who's the Senior Vice President of Advocacy, Practice Advancement, and Policy for the American Academy of Family Physicians, who will be interviewing Dr. Candice Chen, Associate Professor at George Washington University Milken Institute School of Public Health, who is joining us remotely this morning for a great conversation on the public workforce in primary care, which is a critical topic we've talked a lot about this morning. So over to you. Do you need that?
Good morning. As Claire mentioned, I'm Stephanie Quinn. I'm the Senior Vice President of Advocacy, Practice Advancement, and Policy at the American Academy of Family Physicians. We have about 127,600 family physician and medical student members across the country. This has been a really exciting conversation over the last day and a half. We've talked with a lot of different stakeholders about different ways that we can seek to improve access to high quality primary care. And one important area that we're going to dig into is around workforce. Currently, research has shown that by increasing an increase of 10 primary care physicians per 100,000 people is associated with an increase of 51 days of life expectancy. But in this country, we're actually seeing declines. We're seeing, 5 per 100,000 decreases and 7 primary care physician decreases per 100,000 in rural areas. This is associated with a loss of lives of about 85 per day. And so while all of these other conversations are critically important to improving access to primary care, until we really dig into the workforce, I think it's going to be challenging to really truly address health equity and a lot of the other important issues facing our healthcare delivery system. So I'm really excited that we have Dr. Candice Chen with us today to really dig into that topic. Dr. Chen is an associate professor of health policy and management at the Fitzhugh Mullen Institute of Health Workforce Equity in the Milken Institute School of Public Health at the George Washington University. I thought my title was long. Prior to that, Dr. Chen was previously the director of the Division of Medicine and Dentistry in the Bureau of Health Workforce at HRSA, where she led the development and administration of grant programs to strengthen primary care and improve access for underserved communities. And Dr. Chen is also a board-certified pediatrician, where she served in Southeast DC, in our very own hometown here. So, Dr. Chen, I think you have a very unique perch as a healthcare educator, researcher, and clinician yourself to really view workforce. And so we're really excited to have you here. And I'd like to open up just by hearing a little bit about what you're seeing as some of the workforce trends facing primary care.
First, I just want to say thank you so much for inviting me, and thank you so much for letting me come in virtually. I apologize to everyone. I so wish to be in person with you today, and my third grader got me with COVID, and so I am very happy to not be exposing all of you to what it is that I have. And I also apologize because I'm losing my voice a little bit, so I hope the volume is coming in well. Workforce. First off, Stephanie, I have to say thank you for starting off with, does the primary care workforce even matter? Because I think anytime we start with talking about workforce, we should always talk about why it matters. And the evidence that exists that shows that primary care workforce does make a difference for outcomes is a great place to start. Now, what's going on with workforce and what's going on with the primary care workforce? I think that this workforce has faced challenges for the better part of the last half century, really. And we know what those problems are. We continue to face them. We know a number of the drivers that are going on. And we have a lot of hope for some of the things. Actually, coming after the integrated behavioral health panel is great because it's such an example of both the challenges that I think that we're facing and that the workforce faces, as well as some of the hope and the potential that is there as long as we continue to push on those things. So what do we know about the primary care workforce? We know that we have maldistribution issues. We know that in certain communities that there is a shortage of primary care physicians and other providers. When I say that, though, I always have to be very careful because there have been some really interesting primary care workforce projections recently that suggest that there is both a shortage of family medicine while there is going to be an oversupply of nurse practitioners. It almost seems to not make sense, but really says to me, how do we maximize our teams? How do we maximize the workforce that we have? Nurse practitioners are one of the fastest growing workforce out there. And if there are concerns about how we transition them into practice, if there are concerns about how we support them in primary care, right, then those are the things that we should be working on. Aside from maldistribution across specialties, primary care versus specialties across professions, I think I was also hinting at very much this issue of maldistribution across geography. And that maldistribution happens rural, urban, underserved, but it also happens across the United States, that there are different places in the United States that struggle a lot more with workforce. And I think rural is one of the areas that we're really, really paying attention to and have some very specific drivers that make that so, and need some very specific solutions and policy approaches to address that workforce. Beyond the maldistribution of the workforce, I think that there's also the challenge of the fact that even if you have a provider in a community, it doesn't mean that they're serving all of the community that needs to be served. Medicaid participation is an example of this. Now, there are a lot of policy drivers and administrative burden issues and market factors that are driving, for example, Medicaid participation, but we know that Medicaid participation and the fact that providers are less likely to provide service to Medicaid populations is a real access barrier. Moving from that, I think that there is, again, such hope for team-based care, for maximizing telehealth, but I know that probably some of the other sessions really focus on that idea of changing payment models, changing practice support models to really allow the space for that. And I reflect in the last 10 years, you could almost say integrated, fill in the blank, and primary care. And I think that we're really grappling with the fact now that it's not just dropping one more thing on top of primary care, but creating the space so that, and the teams, and making investments so that people can provide that care. Burnout is such an issue. And one of the things I think about with COVID is that we had all of these issues. We knew all of these issues coming into COVID. And then COVID was like putting the top onto the pressure cooker and turning up the temperature, right? And so coming out of COVID, I think we have a lot of concerns that we knew that our rural primary care providers were older, that they will retire and leave even greater gaps in rural communities. In COVID, we know that certain communities, Black African American communities, Hispanic communities were disproportionately impacted by COVID. That's true for the workforce too. And what's that going to do to our workforce? Women in the workforce appear to be disproportionately impacted by COVID. And so there's a lot of concerns about what COVID is going to do. And when we come out the other side with I think that a lot of thought is that we are going to come out of the other side with disparities worse. But workforce is also going to be one of those areas where we're really going to suffer. And I should probably pause. I would like to get towards because as you probably noticed, I haven't actually talked at all about how do we develop produce this workforce yet, and the issues of training and the issues of diversity in the workforce. So let me pause there and see what you think.
Yeah, I think that's a really helpful overview. And you know, I know you've been working a lot on kind of an equity framework with respect to workforce. And so would you talk us through a little bit of that?
Yeah, absolutely. I actually just took you through the latter half of that actually, and we're actually going to be releasing our Health Workforce Equity Framework probably within the next week on the Mullen Institute website. And so, you know, we definitely think about maldistribution across specialties, maldistribution across geography. We think about who the workforce serves, Medicaid populations, uninsured populations, other high need communities that have been marginalized historically. We think about the models of care, right? And everything from how are we going to integrate telehealth, how are we going to develop new teams, to how is the workforce empowered to engage in solutions, the hardest solutions, the health equity solutions, right? And primary care has such a role in that space, has such a potential role in that space. And we think about both fair and safe working conditions with, you know, as we think about our teams, right? A lot of times we focus a lot on the higher income workforce. We focus on the physicians, we focus on the nurse practitioners, sometimes we focus on nurses. But the team doesn't exist without your medical assistant, without your front desk staff, without even more your community health workers. The mental health team, integrated behavioral health and primary care teams don't exist without your peer support worker and your community health workers and your psychologists and your social workers, right? And so, you know, one of the things that I think that we should all be paying attention to is not just those at the higher income levels, but what about not minimum wage, but living wages for individuals, for our medical assistants? What about training costs for our medical assistants? And at this point, I have to really refer to Margaret Flinter at Community Health Center, Inc., who helped to found something called MEMA, which is focused on medical assistant training, affordable medical assistant training. Can you imagine putting people into minimum wage jobs with student debt and what that means for the team? And it's hugely important for the team, because if our medical assistants are burnt out or turning over, that affects the entire team, right? The sufficiency of our medical assistants, right? And so we should definitely be thinking about those things as well. But then actually I come back to the very beginning of our framework and diversity. We have such a problem with diversity. We have an ongoing problem with diversity. And through COVID, you know, that new focus, I think, on health equity, what happened with George Floyd really brought up the racial equity issue again. Diversity really matters, and we are honestly failing at diversity. And we have been failing for decades at diversity, and we're not making good progress. Now, why does diversity matter? You know, one of the first things about diversity that people always come to is that we know that individuals from underrepresented minority backgrounds, from rural backgrounds, from disadvantaged backgrounds, you know, socioeconomic diversity, that when we recruit those individuals into medical school, that they are more likely to pick primary care. They're more likely to serve in rural and underserved communities, right? It actually kind of makes sense, right? Like, you know, for somebody who grew up in urban America to make a decision to go to rural America is a lot different than for somebody who grew up in rural America, has family in rural America, right? To go home and serve their family. Not that it's their responsibility to fill all those gaps, but, you know, it makes sense. One of the things I always like to remember, though, that is it does not become the responsibility of our, Black, Hispanic, other physicians to fill all of the gaps that we have in our healthcare system, right? So we have to be very careful that we don't do that. The other reason that we need diversity is because diversity makes us better. We have these health equity challenges that are complex. They're wicked challenges, right? And there's a lot of evidence that when you put diverse teams together, they behave differently and they come up with different answers. They come up with better answers. COVID, oh my gosh, right? Like what happened with our vaccine rollout? If we had a more diverse workforce, I think, and we had engaged that workforce in creating the solutions, I think that we could have predicted a lot of those challenges. And with primary care, I also think about primary care and that, at the core of primary care is beautiful, right? I think one of the challenges with primary care is there's so much of the hamster wheel that sometimes we forget what's great about primary care, but it's those relationships. And the heart of those relationships is trust. And we needed that in COVID. And we didn't set up our primary care workforce to be able to maximize that. So diversity really, really matters. It's also an equity issue. How do we turn and address equity, health equity, when we haven't addressed equity in our own house, right? So, and I think that becomes a trust issue as well. So diversity. I can never say enough about diversity. And then let's talk about health professions education, right? So when we talk about diversity, it automatically gets us thinking about, well, who are we recruiting? Who are we admitting? What are our admission policies? And those are things that we have to unpack and we really have to address. Right? When we think about, then let's take medical school. When we think about medical school, what is the primary care experience that we're giving to people? And I also will pause here and say, I recognize practice matters, right? A lot of times you'll go to a medical school dean and they're like, there's nothing I can do, right? On the practice side, it's so challenging that I can't get people to choose primary care. And we absolutely have to fix the practice side. But there are things that medical schools can do. Like when we look across our medical schools, we see that some medical schools are producing 50% of their graduates who stay in primary care, and some are producing less than 20%. What is going on there? And why are we not holding our schools accountable? And then there's innovation going on in the field, right? There are schools that are pushing for accelerated path into primary care that also helps with debt, relieve a little bit of the debt, reduce the medical school by 1 year, right? Get people tracked into primary care. One of my favorite innovations within medical education is H.E. Still University at Mesa that does 1 year of medical school in Mesa at the main campus. And then the last 3 years, they distribute their students across the United States based out of federally qualified health centers, community health centers. Think about the partnership it takes to do something like that. But think about the education that's being provided, right? Think about the mission. Think about the priorities that are being imprinted on these students when they're based out of a community health center, rather than unfortunately based out of the ivory tower, right? So there are things that we can definitely do in medical school. And then there's graduate medical education, which is a whole nother. I'm going to stop here before we talk about graduate medical education, because I had a lot of thoughts on that one.
Well, I think it's actually a good segue. What are some of the ways that you're seeing external stakeholders addressing some of the primary care workforce pressures?
External stakeholders, I think that there's a lot of interest. I think that there's a lot of attention, even before coming into COVID, I think that there was rising attention towards burnout. And we were seeing the national academies engaged in an action collaborative. In fact, the national academies and the Surgeon General just released something this past week on advancing activities around burnout. And so the federal government is doing things. I should reveal that we are acting as a technical assistance center for 44 grantees from HRSA, from the federal government, to start addressing burnout. And so there are investments from the federal government, both in express investments like grants, as well as kind of thought leadership, I would say, from the Surgeon General, and then as well as from organizations like the National Academy of Medicine, right? Like to raise these issues up. One of the interesting things I always think is that, we had the triple aim, and then we had the quadruple aim, and now we have a little bit of the quintuple aim. And I think there's occasionally a little bit like, oh my gosh, what else are we going to add to this thing, right? But I actually think it's incredibly important that both worker well-being and health equity are there. Some people will say, oh, well, that should just be integrated into everything. The challenge is that when you're not explicit, when you don't say burnout, well-being, when you don't say health equity, sometimes we forget, right? And we pass policies that have unintended consequences. There's so much that you can do to address access, quality, and cost at the detriment of your workforce. And that's historically what we've done, right? And so it's really important to keep that up there. And then we see interesting things happen. You know, one of the things that I've been really impressed with the ACGME on is that they are now requiring parental leave, that every residency program provides parental leave, right? Like that's a huge step forward in terms of our private regulatory laws. And then one of the other interesting things that we're seeing, I think particularly across graduate medical education programs, but also with like our nursing workforce, is somewhat the rise of unions, right? And we're seeing definitely nurses unionize, and that I think has been a little bit historically more common. But now we're really starting to see kind of a rise in residency programs unionizing across the United States. And why are they doing it? Right? I think that you know, occasionally people will focus on this issue when they negotiate for income, and you know, I think there's always an issue of fair income and making sure that people, you know, can afford the cost of living in various places, and that the income is fair. But I think that a lot of that we're seeing a rise in the unionization of residency programs, more because of what happened in COVID, that those threats to physical safety, those threats to psychological safety, and the extreme hierarchy and power differentials within healthcare, that I think that we are starting to try to unpack a little bit, and protecting residents who want to advocate both for the safety of their fellow residents as well as for health equity, right, in their spaces. So there are a lot of interesting things I think that are happening at the federal government down out to communities in this space addressing burnout.
That's really helpful. We touched on it a little bit, but and I hear you have some thoughts, but what do you think the federal government could be doing in terms of graduate medical education or other levers that they could be pulling?
Yeah, absolutely. Well, let's start with graduate medical education, and let's start with something positive, right? There's a program out there called the positive for primary care. There's a program out there called the Teaching Health Center GME program. The Teaching Health Center program was established in the Affordable Care Act. Some very specific aspects, in contrast to the other major funder of GME, well, the major funder, the gorilla in the room, Medicare GME, is that teaching health centers must be sponsored out of a community-based ambulatory setting, and it can only be in certain primary care specialties, including the typical ones that you would think about, but also including geriatric, psychiatry, general and pediatric dentistry. And the program was established in 2010, kicked off in 2011, and there are teaching health centers largely based out of community health centers across the United States. And they have demonstrated that they produce people who will stay in primary care. They have demonstrated that they produce people who will work in rural and underserved communities, that they'll stay oftentimes in those community health centers, right? I think it's also really fascinating, right? One of the things I always like to remind people about teaching health centers is it's not just convincing people to stay in these communities, but it's training them to be better providers. The care provided in FQHCs is sometimes the most complicated care for some of the systemic reasons around the people who access care there, right? Oftentimes delays, oftentimes a lot of social determinants driving their ability to access care and, you know, and their health and well-being, right? It's the hardest medicine there is. And primary care itself is hard, right? It's the thinking. You never know what's going to walk in your door. You have no idea, and it's always a combination of social determinants as well as you know, medical and healthcare issues, and the challenge of being able to develop relationships where you can elicit what the real root causes of the issue are, not only the medical ones, but the social determinants, right? And then the need to be able to address all of those things. Primary care is some of the most challenging medicine out there. Right? We don't recognize it for that. I think oftentimes it gets, you never hear about a family medicine person who didn't hear, you're too smart to go into primary care, right? Holy smokes, we need the smartest people. in primary care, right? And then we need to give them the space to be able to do the job that they came into primary care to do. And now I totally got distracted from what I was talking about. Teaching health centers. And so the Teaching Health Centers is such an interesting program. It's funded at $126.5 million a year. It's funded through FY23. Teaching Health Centers has been a challenge because when it runs out of funding, it runs out of funding. Congress has to act to provide more funding. Interestingly enough, with COVID, Rescue Act put an additional $330 million onto the Teaching Health Center program to expand the program and to establish additional teaching health centers. But in September of 2023, that program is going to run out of money, and we'll need Congress to act to continue this successful program. But then the other thing that I would point out is the $126.5 million compared to Medicare GME, which is funded right now at about $15 billion annually. And on top of it, Medicare is an entitlement program, which means those teaching hospitals don't have to wonder if the funding is coming year by year, right? Medicaid, on top of it, between federal and state, puts an additional about $4 billion to support residency programs. In total, with VA putting about $1.5 billion, we're looking at $20 billion of investment by the federal government from taxpayers' money to support the training of our future physician workforce, largely physician workforce. And, there was a 2014, first MedPAC said it in 2010, the IOM, now the NAM, said it in 2014. We're not getting what we need out of the GME system. For that large federal investment, we are not getting. Why are we only at, we're looking at less than a third of our physicians in primary care, right? And, I think one of the things that I would always advocate for is to get that NAM report off of the shelf and really relook at it. I mean, they said it pretty bluntly. We're not getting what we need out of the current system. And they made some pretty strong recommendations about reforming, including pulling back some of that money, not to call it savings, but perhaps to push it back out into the system to start getting some of the things that we really need. Thinking about the geographic distribution, right? Physicians tend to locate near their residency programs. So where those residency programs matter. In specific specialties, right? Right now, Medicare GME doesn't require anything about what kind of specialties hospitals train, right? You just have to meet the requirements of the formulas and the reporting and the administrative reporting, right? One of the things that we could start with, because those would be major reforms, but one of the things that we could start with is just start collecting and measuring GME outcomes across programs. How many people stay in primary care? How many people go into rural and underserved communities? How many people are taking care of Medicaid populations? And that's relevant no matter whether you're in primary care or whether you're in specialty care, right? And when do we start holding those institutions accountable? So there's a lot of work and there's a lot of potential in that area, and there's a lot of money and investment that could be, that could be used and targeted towards some of these gaps that we really have.
Yeah, I absolutely agree. And I think one of the challenges with the Teaching Health Center GME program is that it's currently in 26 states. And I think the challenge getting Congress to focus on something that isn't everywhere, and some members that haven't seen for themselves what these teaching health centers can do, is one of the simplest barriers to overcome, is just getting them in those areas. And so, I agree, it's a small but mighty program that I think is a good demonstration about how you shift thinking from primary care in a hospital setting to the community setting. So let's see. Let's end on a positive note. What makes you hopeful about the future of primary care?
Oh, I think, so many things make me hopeful about primary care. One is I cannot go back and re-emphasize, we need a culture and a PR campaign for primary care, because primary care is wonderful, right? Like, as a primary care pediatrician, I describe it sometimes as that joy that I have when I'm walking down the hallway and that 3-year-old maybe comes and you get that like knee hug, right? And that's just a representation of the connections that we make with patients, right? I think one of my greatest victories was when I was in clinic one day and a resident came out of a room and said, "This mom just told me that she quit smoking because you told her to quit smoking a year ago," right? The differences that we make to people, right? That at the core of primary care, it's everything that's good about medicine, I think. But what we need to do is remove everything that's bad about medicine from around primary care, right? But I think that we have the great hope, right? When we look at the movement that's going on with value-based payment, when we look at the advocacy that's being done around truly making payment changes, increasing primary care spend, right? Let's recognize the value.
And also some of the more innovative approaches to care and how, telemedicine and other, other supports are making it easier to engage patients, I think is really changing, the impact that primary care can have and the reach and really kind of strengthening those relationships.
Yeah, absolutely. I think telehealth and telemedicine have great potential, right? Whether it's direct care that's being provided, whether it helps private. Actually, when we look at Medicaid participation, when you ask primary care providers, why don't you take Medicaid? One of the reasons they say is because for my Medicaid population, when I need to refer them, there's nobody to take them, right? And so there's potential there. It's like, how do you support the practice, right? But I think it's also, again, I cannot harp on enough, right? Like, you cannot just add one more thing and just say, do this as well, right? And so we really have to fix the entire model, which includes payment and what we're incentivizing with payment, right? And some of that is going to mean that we're going to need more workforce in a lot of different places, I think, right? Like, as a primary care pediatrician, right, I am so scheduled at every 15 minutes when I walk into clinic. In some FQHCs, primary care pediatricians are scheduled at every 10 minutes. It's unsustainable, right? That's the hamster wheel. People don't talk about the hamster wheel as much anymore, I think, because I think with the hope of value-based payment, the hope is that we move away from the hamster wheel. I don't think we're there yet, but we got to keep pushing on it.
Well, thank you so much. I would like to give the group an opportunity to ask questions if there are questions. Anyone? There's one coming your way.
Okay.
Hello, my name is Mary Malati. I'm actually just graduated medical school and I'm starting internal medicine residency, hoping to stay in primary care. And I really appreciate your insights and thoughts on, what barriers there are to retaining residents to stay in primary care and to stay in underserved communities and so forth. Dr. Chen, do you by any chance have any ideas of how or things that are being done or being advocated for right now in the GME setting to help with that issue, especially with also your focus on diversifying the workforce? There are a lot of barriers that make the environment of residency, for example, like hostile towards diverse students and those kind of things. What are some things being done right now to help with those things?
Yeah, let me start with what I'll call anti-discrimination, equity, and inclusion. We have a problem. We know that we have a problem in healthcare and across society, but let's recognize that we've got this in healthcare, and it definitely affects our trainees. It affects our trainees in residency. It affects our trainees in medical schools. I think one of the promising things is that we are starting to grapple with this. And even some of our major organizations are starting to grapple with these issues. I mentioned the ACGME, right? But the American Medical Association, grappling with their own history of racism, to be honest, is an important step forward. I think that empowering our students and our faculty is also critically important. And when we have kind of from above and from below demanding change, right? That's when we start to change. But then there's a whole lot of work to be done, right? Within our institutions that are just starting to grapple with it. What are the existing policies? Why are we so dependent on the MCAS, right? And what are the things that make us act the way that we do? Can we change those things around us, the policies around us? Are there things in accreditation that are making us behave in certain ways that is not consistent with equity and inclusion? Are there things in our accreditation and or in our organizations that are insufficient in protecting our trainees and our students and ultimately our healthcare workforce, right? I think that those are all things that are being grappled with right now, and we're starting to see organizations start to move. But we cannot let our foot off that accelerator. We have to keep pushing on it. I actually think that is part of the reason that we're starting to see a lot more unionization across. It's that recognition that, well, I'm just going to say this, and this is from my own experience, but medical education, well, and actually we're seeing it a little bit if anybody's been following Stanley Goldfarb, historically there was a little bit of a keep your head down, do your work, don't make waves, put the blinders on, right? And I think that as health equity is rising, I think as diversity, equity, and inclusion issues are rising, people are starting to say, whoa, let's take those blinders off and look around, right? What's going on, right? And then rather than having our power, giving away our power, right? As healthcare workers, we're starting to realize, whoa, no, I need to reclaim that power and I need to get together with people who care about the same things as I do so that we can start advocating for change. So I think that there's a lot going on. That actually makes me hopeful. I see the students, the residents rising and reclaiming their power. And I know it's a little bit cheesy, but I think that's our future, right? That gives me hope. That gives me a lot of hope. But don't let off. I think that's the message. Don't let off.
Hi, Candice. It's Judy Steinberg.
Oh,
So nice to see you. So I have a question. Thank you so much. And I'm from the Office of the Assistant Secretary for Health and leading the HHS initiative to strengthen primary health care. So understanding that there are a lot of statutory or legislative barriers in the way the GME program was set up back in the 60s. What have you seen as some exemplar programs that have been able to be developed? Maybe I think you may have referred to H.E. Still's a residency program that we can learn from and incentivize for scaling up.
Yeah. Hi, Judy. It's nice to see you. No, I absolutely agree, right? Like, just really quickly, a really quick comment about GME. Occasionally, you'll see Congress ask CMS, what is going on with this GME, program? And why are we not getting what we need out of the program? And I'll tell you, a couple of years ago, we actually did a paper that looked at the variation in per resident payment across teaching hospitals and actually suggested if you just capped it at the $150,000 that the teaching health centers pay us, that you might pull back. It was a little over $1 billion. And again, with that idea of, hey, with that $1 billion, you could increase the teaching health center program by tenfold, right? And about a week after we published that paper, Senator Grassley sent a letter to CMS saying, what's going on with Medicare GME accountability and transparency and accountability? It took a little while, but CMS eventually wrote a letter back to the senator that was basically like, Medicare GME is established in law, and there's nothing that we can do about it. The only people that can change it is you, Congress. So it's just something to kind of keep in mind of where's our target in terms of big reform. But beyond that, I think that the teaching health centers is it, right? Let's be honest. The teaching health centers is a whole different model. And the thing is sometimes people look at the teaching health centers program and think all of the training is in the FQHC, and it's not. They still have to meet the requirements of any family medicine, pediatrics, internal medicine, psychiatry residency program. They still have to partner with hospitals. but it flips when you send the money to a different organization, it flips the power dynamic, to be honest, right? And it allows the F2HCs and the community-based sites to set the mission and the priorities and to start to innovate a little bit, right? And so how much more of the training is spent in community-based settings? How much did they integrate community engagement activities into their residency programs? One program that I still work with, and I'll just share, I serve on their GME board, is a program in Detroit. And they partnered with, goodness, and I hope I don't get the organizations wrong. I think it was University of Michigan, that to provide a population health certificate for all of their residents, right? The content is different, the mission is different, right? And the thing is like when we embed training inside of community health centers, oh my gosh, right? Like when social determinants, that idea of engaging in social determinants started getting hot, right? And our ivory towers started going, we need to do this, right? Community health centers have been doing it since they were founded. If you followed when Jack Geiger passed away, people talked a lot about some of Jack Geiger's original work when he founded founded the first two community health centers in the United States, one in New York, the other in Mississippi, right? And the work that he did early on, writing prescriptions for food, right? This is in like the 1960s, right? He was writing when people were hungry and had food, I don't think we were calling it food insecurity at that point, but had food insecurity, right? He was using some of the funds that he was receiving from the state, I think at that time, to be able to provide food. And when he was criticized on that and asked to please stop, his response was, well, the last time I checked, the treatment for hunger is food, right? So, community health centers have been doing it for a very long time. Community health centers have been innovating oftentimes based on, limited resources. They've innovated, right? And they've been early engagers on issues of social determinants of health and community engagement, community partnerships, right? So to be able to train in those settings with support, by the way, right? I think a lot of people would want to train in those settings. And community health centers need to receive, financial or other support to be able to support that kind of training, right? But it is, in my opinion, it's an ideal form of education for future primary care providers. And actually, one of the interesting things I'll just share, actually before my time at HRSA, I worked on an evaluation of the teaching health centers and had a chance to go out and visit some of them. And one of the things that really struck me is one of the teaching health centers mentioned that large local healthcare system, maybe not exactly what we intended for the teaching health centers, but said back to him one time, hey, can you produce more of these residents? We really like them because as we're trying to innovate with new models of care, they really get it, right? Again, new models of care, being resource conscious as you're practicing, but the product of these teaching health centers is different and arguably better. I think the teaching health centers is a real good example of the way training should be. Can I add one? I don't know if there's anybody else in the room who wants to ask a question, but I would be remiss not to mention the HRSA programs. Primary care training enhancement, geriatric workforce enhancement program, the nursing workforce program, which have been supporting, for example, nurse practitioner residencies, which are starting to take, I think, some root, particularly in community health centers, very much with that idea of like, where is it that we want our providers to get a little bit more support and training so that they can be successful providers, right? And they're small programs, but they are really important. They're really important for training programs, both to, as they face kind of all of the other incentives that drive people away from primary care, that drive medical schools and healthcare organizations to prioritize some of the other specialties over primary care. Those programs are incredibly important and they could be expanded. And what they really help training institutions do is turn, right? So as we're talking about integrated behavioral health and primary care, you don't just get to say integrated behavioral health and primary care and it happens, right? There's a lot of upfront investment that has to happen to help organizations turn. And what better place to do it than in training institutions where then every one of your residents becomes this little seed that goes out and says, this isn't like what I experienced in residency, right? Where is the integrated behavioral health and primary care? Where is the rest of the team, right? And now I don't want to send them out there to be frustrated by that. That's why we have to work on the practice side as well. But you know, when we train people to expect something different, they expect something different, and then they hopefully have the opportunity to move healthcare organizations around them.
Thank you.
So good morning, Candice. This is Sean Martin from AAFP. Thank you for joining us this morning. So a little bit of a thought-provoking question. So big changes needed, usually need big disruption. So one of the things, when you think about the pipeline, so from matriculation to undergraduate university through residency, we have a very traditional view about what that pipeline or pathway, if you will, involves. So as a workforce, as someone who's spent their life thinking about how to increase workforce, is there room for innovation that maybe you don't need 4 years of undergrad, 4 years of medical school, and 3 years of residency? I mean, maybe that 11 or 12-year pathway becomes 7 or 8. And what are the possibilities of disruptive policies of that nature being pursued in the country, and how would that impact, from your perspective, the future primary care workforce?
I say yes, right? When we look at the existing policies and we look at the existing structure, right? Like the environment is evolving. If we go all the way back to, and the Flexner report had lots and lots of issues, but when we go back to 1910 and the Flexner report, one of the big concerns at that point was that in 1910 healthcare system, right, that medical education wasn't science-based enough, right? And in 1910, that was probably somewhat true, right? And so that moved towards more evidence-based medicine, ensuring that there's a minimum quality of medical education. That was not unreasonable probably in 1910, putting aside all the other issues that the Flexner report had at this moment, right? But it's not 1910 anymore, right? And what we have going on in our healthcare systems looks a lot different, and the guardrails that we have around our healthcare system and healthcare delivery looks a lot different. We still got a lot of work to do in those areas, but then when you embed education into those, right, could we have a little bit more flexibility? Actually, the prime example of that is our osteopathic medical school, right? That grew up we had our allopathic, and then our osteopathic medical schools grew up around that, right? And as organizations, they look a little bit different. They had a little bit more flexibility in doing some of the things that allow something like the AP skill model, right? And they produce a lot more primary care and rural and underserved providers, right? And I think right now is a great time to relook at what are the things in our accreditation pathways that are, and one of the interesting things about accreditation is sometimes there is what is a real requirement, and sometimes there is what is a perceived requirement in accreditation. I think that the ACGME is doing some work to try to help particularly rural residency programs really push up against really recognize what are the real requirements versus what are the perceived requirements. But I think that there's always an opportunity to do more. And as you probably know, that there are 3-year medical school to accelerated primary care tracks, right? But can we do more? I think absolutely. And at that point, we need to look at the other things that are it's not just accreditation, right? Licensing requirements, scope of practice requirements in states, right? What are the things that are keeping us from innovating? But at the same time, as we innovate, I also, believe that we should continue to track what are the outcomes. We don't make assumptions as to what kind of outcomes that we're going to get.
Thank you. This has been really, really informative, and we really appreciate all the work that you're doing and getting the word out there. So unless there are any questions, let's see. Is there? Oh, good. And our next speaker will be Ms. Kina Fong from Elation.
Thank you. I think my job here is to stand between you and lunch for a few minutes, but just wanted to quickly introduce myself. My name is Kina Fong. I'm the CEO and co-founder of Elation Health. We are a proud founding member of the Primary Care for America Collaborative. A little bit about Elation. We are the largest and most trusted network for high-value primary care. We build a technology platform that services primary care entities, anything from independent solo docs up to multi-thousand clinician organizations. And I want to make sure that everybody knows that we're taking a break in the programming right now, and we will be reconvening at 1 o'clock. So hope to have everybody back here. We're going to have a series of 3 unique panels on primary care innovation. And then at the end of the day, I'll have the honor of wrapping up and sharing a few words about primary care to wrap up the really incredible conversations today. But thank you. Oh, I should have started here, but thank you, Stephanie and Dr. Chen, for the very insightful conversation. And we'll see you back here at 1. Okay, thanks.